First of all, I would like to thank Professor Slizat-Korn for inviting me to this excellent meeting. I want to start with a quote. The primary goal in the treatment of acute type A aortic dissection is patient survival. If you don't have a patient who survives the index operation, you don't have to worry about residual dissection. And actually, if you look at the real world, and this is a Canadian survey by all cardiac surgeons, most of the cardiac surgeons are doing less than 5 acute type A dissection cases per year. That's not a great number. And even if you are an excellent and experienced surgeon, and this is a group from Germany with 160 type A dissection, and they divided those type A dissection in an aortic team and a well-experienced cardiac team with more than 2,500 cases, you still see that there's a huge difference in outcomes. You need a lot of experience to actually treat those patients at the first sight. The gold and standard surgical therapy is ascending or hemiarch replacement with an open distal anastomosis because you want to prevent those 3 complications. And if you do that, you can achieve quite relatively good results with this operation. And this is latest data from IRA 2 weeks ago at the ACC. You can have a mortality of 13% of all comers. So actually, you convert an acute type E dissection into a subacute or chronic type E dissection. And actually, if you're doing that, you can go home and have fun, like for example, Malcolm is doing in Hong Kong after he repaired this ascending aorta. So do you have to worry about the residual dissection after type A repair? Actually, no. You just observe regularly the dimension of the aorta, of the arch, and the descending aorta. The only thing where there's one exception is if you still have ongoing distal malperfusion right after the index operation. But this is actually very, very rare. If you look at the Gerada database with over 3,000 patients, you have only 5 to 7% of patients where you do the ascending, you fix the ascending aorta, and you still have some malperfusion in the visceral or peripheral organs. And actually their TEVAR or fenestration is indicated, and that's the only indication to act acutely. Otherwise, you just observe those patients. So which parameters you should use to observe after type A dissection? Well, there's one paper 10 years ago by Song from Korea where they looked actually on type B dissection sort of after type A dissection, and a false diameter of greater than 22 millimeter was somehow an indicator for higher events in the postoperative period. The other one is, of course, the true lumen, whether it's thrombose or patent. And as you can see here, if you have an occluded false lumen, you have better survival than the patent one. And one of the worst one is if you have a partially thrombosed lumen. And the third parameter, and this is a work from Randy Grebe, is somehow initial diameter on the descending part of more than 4 centimeters. Nevertheless, you have a reoperation rate of only 16% after acute type A dissection, even if you have those parameters. And this is a paper that just came out a couple of months ago from a Nordic group, and they looked at 1,200 patients looking on ascending, hemiarch, and total arches. And the freedom from reoperation at 5 years was 96%. So you don't see those patients very often after acute type A dissection. And even it doesn't matter if you do ascending, hemiarch, or total arch, there's no difference in the reoperation rate. So after successful index operation, you wait till the patient develops an arch aneurysm or it develops a thoracic or thoracoabdominal aneurysm. But most importantly, these are now elective cases. This is an acute setting, and you can send them actually into high volume aortic centers. With regard to guidelines, the European guidelines say you have to operate on the arch when it's 55 millimeters. The American guidelines just say if you have an enlarged aortic arch, so I would say it's the same 55, and you can achieve very good results. This is actually data from Dr. Coselli, 119 patients with an operative mortality of 8%. So you can achieve very good results even if you do a redo operation. What about the thoracic aorta? Mostly the guidelines are saying you should use TEVAR, but once you don't have a technical possibility, you should operate on those patients more than 60 millimeters. The American